You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Today we're talking about carpal tunnel. Before we dive into what it is, how to diagnose it, and how to treat it, we just need to go over to the anatomy very quick. So if you're a clinician, I'm sure you understand this. But the carpal tunnel is a ligament, the transverse carpal ligament that spans from the trapezium on the lateral aspect to the hamate on the medial aspect of the wrist on the proximal carpal bone, thereby making a tunnel where a few things traverse. The flexor digitorum superficialis and profundus tendons run through there, and then kind of in a separate compartment, the flexor carpi radialis tendon along with the flexor pollicis longus tendon. The one that we're talking about today that runs through that tunnel obviously is the median nerve. So very quick we can say, well, what is the thing that jumps off of the median nerve? The recurrent branch of the median nerve does not pass through the carpal tunnel and would present with only paresthesia, dysesthesia in the thumb by itself, which immediately rules out classic carpal tunnel. So there's a quick rule out. But the median nerves, or the median nerve's derivation, is going to be the first 3.5 digits. So all of the thumb, all of the index finger, all of the middle finger, and then half of the ring finger. And that half is obviously the medial side of the ring finger. To have true median nerve compression in the periphery, you would almost have to have that entire presentation, because you can't have reduced axonal or axoplasmic flow to just a certain portion of the nerve. When you get into the nerve root itself, whether you're on the anterior or the ventral versus the dorsal aspect of the nerve root, you obviously on the anterior, the ventral aspect, you'll have more of a motor effect, and you get into the posterior, you're going to have more of a sensory. We might leave that for a different video. So let's dive into, what is carpal tunnel? Obviously, it's what we said. There's 5 stages. Basically, going through these 5 stages, we don't need to list exactly what it is. Going through the 5 stages is just going from transient symptoms, usually at night or first upon waking, in this presentation where it's just numbness, tingling, paresthesia, moving to now I'm having symptoms all of the time. Now I have symptoms with fine motor loss or sensory loss. Then I get into atrophy and eventually plegia of the muscles, in particular in the thenar eminence. You'll know when you see these cases of obviously atrophy in here, the differential diagnosis when you see atrophy in this area is going to be things like, do they have atrophy obviously anywhere in the hand, which is leading you further up the chain. But then also osteoarthritic change in the first carpal metacarpal joint, because once you get severe enough osteoarthritic change, it makes it harder to leverage the muscles in the thenar eminence. There you'll have atrophy again. And also direct trauma to the thenar eminence can cause some atrophy. You also have to rule out scaphoid fracture that's went avascular necrotic, and thereby leading to surface level atrophy. So that would be the classic presentation. If we get into clinical predictions for this, the first thing that comes up is this, when you're in the history, somebody says, when the symptoms come on, I shake. And, every clinician's then salivating, maybe not, depending on do you want to treat true carpal tunnel syndrome or not, that's maybe what it is, which that shaking, we always kind of say it's like if you bumped your head, you rub it, that mechanical input, right, that perturbation to the nerve can override some of the paresthesia, because again, a dendrite, a free nerve ending, whatever you're going to call it, a sensory nerve ending, in the periphery is going to go into the dorsal horn, whereas the motor output and the paresthesia, so you kind of can compete with these two things because they're coming in different areas at the nerve root. So something we do not do in the clinic, wrist ratio index greater than 0.67. So what that is you're taking the AP dimensions of the wrist divided by the medial to lateral dimensions of the wrist, and if it's greater than 0.67, that's a higher clinical predictor of carpal tunnel syndrome. If I'm saying this right, a Trocchi-Lyrine 6-item scale and the Boston symptom severity scale, which is an 11-item scale, even though those have two different point systems, 6 and 11 points, a mean score of 3 across over 200 patients was found to be clinically or significant enough to predict true carpal tunnel syndrome, which when you dive into the literature on almost any diagnosis, in particular carpal tunnel syndrome, you start to realize that we're not really that good at diagnosing specific etiologies because we're dealing with humans, which is the whole reason that I do videos like this, that it's rarely a diagnosis. It's a concomitant of multiple things. An age greater than 45 years is in the top tier clinical predictive criteria, but then we go down into noteworthies, and I think some of these are noteworthy, but they have a lot of crossover, and we're going to discuss this. So women are 3 times more likely to develop carpal tunnel syndrome. Also, people with a Baton criteria, positive Baton criteria, are more likely. So these play hand in hand. And then 20% of pregnant women will present with symptoms. So how do these all have crossovers? Well, women are typically more mobile than men in terms of soft tissue. Obviously, a positive Baton criteria. So you have your brachial radial index. You have pulling your 5th digit back beyond 100 degrees. So you get points on each side for these. So brachial radial index bilateral 1, 2, pinkies bilateral 3, 4, elbow hyperextension 5, 6, knee hyperextension 7, 8. Being able to palm the floor with your knees straight and a toe touch 0.9. Bonus point for those very stretchy people is hyperextensibility through the skin, which throws you maybe into the category of things like Marfan's. But it makes sense that if you have more pliable, like you have a collagen disruption disorder, you're just more hypermobile, whether that's physiologic or now we're seeing more an environmental hypermobility due to maybe lack of movement and motor development early in life, due to our just amazing movement culture, that you will traction the nerve or try to move into the nerve or collapse the carpal tunnel more often than somebody that has a little more rigid structure. And then same thing happens with pregnancy, that we get a release of hormones, not we, women, of oxytocin and relaxin, which changes the soft tissue profile in preparation for birth. Now, the last one here in the noteworthy predictive criteria is hypothyroidism. When you look at the literature on this, it basically shows that hypothyroidism, when they are gathering the participants for studies, there's a much higher ratio, anywhere from 3 to 1, 4 to 1, women to men with hypothyroidism. Maybe not in our current day and age. We're starting to see across the board everybody's thyroid's getting beat to hell. But so there's a bias of women already, which we already discussed that in the previous criteria. And then most studies bias women maybe because of the symptoms that are associated with hypothyroidism, weight gain, and the fact that women may be more likely to seek out medical advice when weight gain is one of the primary symptoms. When you see that, I don't think there's strong evidence within the studies themselves. It's just a correlation that more people with hypothyroidism have carpal tunnel syndrome, which we just said women are 3 times more likely to have carpal tunnel syndrome. I'm not standing on hypothyroidism has a tie to carpal tunnel syndrome by itself, but maybe I didn't look at the right study. Basically, we're walking down the path of, hey, we're taking history. What's the presentation? Is it only at night? Is it now during the day? What did we see on physical exam? Taking in all these clinical notes. Okay, we got a woman. She just had a baby a year ago. She developed probably, you're walking down the history. Now we're getting into physical exam. What are the orthopedic tests? As much as orthopedic tests are maybe not the best thing in the world, classic tests for carpal tunnel syndrome, like Phelan's, reverse Phelan's, Tennell's, or Kingery signs. We get on the carpal tunnel and we're tapping, looking for a reproduction of the paresthesia or numbness, tingling in that median nerve distribution. Carpal compression, it goes by a couple names. Bracelet, Durkin's test. We're going to take our finger, thumb, and then forefinger on the other hand and create kind of compression over the carpal tunnel. Hold for 5 to 10 seconds. Again, looking for reproduction of symptoms. One I'm not a huge fan of at all, hand elevation test, which is bilateral elevation, looking for symptomatology. Right here, we're not obviously testing the carpal tunnel anymore. I mean, we're bringing into effect cervical spine, things like thoracic outlet syndrome get thrown into there. How do we differentially diagnose those out? Reproduction of actual median nerve distribution is the key here of where are the symptoms at, which sometimes is tough because people that have non-severe symptomatology sometimes have a hard time discerning where the symptoms are actually at. But that's what your job is as a clinician, is determine, what am I seeing? What's the reproduction here? But I'm just not, there's a bunch of stuff we're looking at here. Obviously, a bunch more moving parts are drawn into the scenario. Moving away from, actual carpal tunnel tests, we still have to rule in, rule out cervical spine, which we're going to talk about double crush here in a second. But if we're just looking at the cervical spine for reproduction, first of all, to have the cervical spine just compress the median nerve is an impossibility. We can have certain nerve roots that are going to be playing into the median nerve more than others. But now we have to kind of start taking into account what would we have with cervical radiculopathy versus a peripheral nerve entrapment or nerve compression, wall area degeneration through that nerve. Cervical nerve roots being anywhere from C5 to C8 for the median nerve. So again, we have multiple levels that feed into the median nerve. So to imagine that we'd have multiple levels of compression due to discogenic pathology, lateral foraminal stenosis, central stenosis, probably not likely. So to have just that distribution from just a cervical component. But again, we'll talk about double crush in particular here in a second. So how do we rule in out cervical spine? Well, things like, maximal foraminal compression become a pretty good test in my opinion, because we can do, Jackson's and all these, but closing down the neuroforamen and seeing do we get, peripheralization of symptoms, maybe taking somebody through a McKinsey MDT assessment and diagnosis, along with obviously hands-on palpation, determining do we have reproduction of symptoms in range of motion, do we have derangements, dysfunctions, restrictions, and then going through possible McKinsey treatment is both a diagnostic criteria and also treatment. Do we get reproduction or alleviation, centralization, peripheralization? So those are all things that I think should be done with any peripheral upper lower, because we know, for instance, from the McKinsey Institute, that upwards of 81% of wrist symptoms have a cervical component. So that being said, let's dive into the double crush debate real quick, and then we'll get back to some other tests and then finish up. Funny enough, when you start looking into double crush syndrome, this was originally proposed. Let's go back here, and I have all of these studies in the notes here in the comments. But Upton and McComas proposed this quite a while ago, and they actually proposed the mechanism of double crush syndrome before we fully understood axoplasmic flow. One of the best literature reviews that I saw was actually done, was out of the Journal of Chiropractic and Osteopathy from 2008, and it labeled Carpal Tunnel Syndrome, the Double Crush Hypothesis, a Review of Implications for Chiropractic, which is looking at a lot of chiropractors in particular tend to lean on there's a cervical spine component in true carpal tunnel syndrome, or in carpal tunnel syndrome, and saying it's overdiagnosed. But what I found interesting here were numerous things, but I really like this quote, because when we're talking about a nerve entrapment, if we're talking about double crush, this article is trying to say, well, does it exist? One of the first things you see across the board in numerous articles here was, I'm looking at another one real quick, the incidence of double crush syndrome in surgically treated patients. This is from 2002 out of... what journal is this out of? Out of Spine. They look at this crossover, and this is talked about in this other article out of Chiropractic and Osteopathy, that they looked at a review of over almost 91,000 patients, and the crossover that they're looking at was the incidence of carpal tunnel syndrome or peripheral ulnar nerve compression and cervical radiculopathy. So somebody that had cervical radiculopathy, and then did they have CTS or ulnar nerve compression, was found to be anywhere between, respectively for carpal tunnel 10% and then around 3.15% for ulnar nerve. Then they looked at a crossover of having both of those. So what the author of this other lit review out of Chiropractic and Osteopathy, which is Russell, is trying to say is when this was originally hypothesized by Upton and McComas, they just looked at the fact that people had cervical complaints, neck pain, maybe they had peripheralization with certain movements, and then they also had classic carpal tunnel syndrome symptoms. But what he was saying is that you can't correlate the two together just because they couldn't prove that they actually had nerve compression even though they had cervical complaints. Because in his own literature, or in his own lit review, He pulls a quote from Nemoto, which that article is cited in here, that is a study that was done. Well, let's see if we open this study up itself. All right, one sec here. So that was done in the Journal of Hand Surgery in 1987, so quite a while ago. But it compared the effects of 2 clamps with those of 1 on the sciatic nerve of dogs. Although a single mild compression produced a partial conduction block and mild axonal degeneration, mild compression, so no more compression, the same amount of compression, same, I'm assuming millimeters of mercury compression at 2 sites produced a complete conduction block and severe degeneration in some animals. They also found that recovery was poor if only 1 of the 2 clamps were removed, supporting Upton and McComas' concern that carpal tunnel release may fail to relieve patient symptoms. So what that tells us right there is a few things. We talk about on our clinic a lot that there are people within the chiropractic field in particular that will say to have a true nerve entrapment, which is almost an entire different video of what is an actual nerve entrapment, would say that you have to have 2 sites of compression to have a nerve entrapment, which maybe that's coming from, articles like this. Well, in this scenario, what we're seeing is there's a much higher likelihood for severity of symptoms with 2 areas of compression versus 1. So if we had compression at just the carpal tunnel, we may not see severity of symptoms like we would if we did have a double crush syndrome. Now, one of the more interesting ones that I saw, and this gets into... let's pull this article, that there was basically a much higher prevalence, over 70% prevalence of lacerous fibrosis entrapment with pronator teres syndrome. So when you had pronator teres entrapment, you almost always had lacerous fibrosis, which if we think lacerous fibrosis is a thickened piece of fascia, we know now that fascia is a contracting, albeit slow contracting tissue. Those two have attachments, so maybe that just goes hand in hand, that it's almost within the same structure. But that was showing, again, 2 sites of compression, because that is one of our entrapment sites, which we'll talk about here in a second. So all that to be said, this idea that there is this, Russell in his article, it's kind of a little tongue-in-cheek. He pulls a quote from the internet, basically just saying, there's a chiropractor on a website that's saying that he believes or she believes that 90% of carpal tunnel syndrome has a cervical spine component. I don't know where the data is pulled, and that's what he's getting at, is can we try to, pull back the kimono on this a little bit and actually figure out what's going on. So is double crush only a cervical spine thing? No, there are articles on double crush syndrome and knee pain with the infrapatellar branch of the saphenous nerve and, upstream effects from other nerve compression. But it's something to determine now that you have to look at, are there other sites of dysfunction, which maybe that's led by symptomatology, maybe that's just led by, hands-on palpation, examination. But I think all of the best in the world, what technique, methodology, whether it's Stecco, neurodynamics, active release, they're all going to be looking for dysfunction up and down the chain of a nerve. And it's just, what's the system or the process that you go about doing that? So this leads us to, how do you rule in and rule out carpal tunnel syndrome, true carpal tunnel syndrome? All the stuff we just talked about, I think we're finding out that it's rarely that's by itself. And there's another article that I pulled up here that looks at a histological change. So it's called The Myth of Median Nerve and Forearm and Its Role. The Myth of Median Nerve and Forearm and Its Role in Double Crush Syndrome. It's an odd title because there's the myth of median nerve. I know it's saying the myth of median nerve in forearm. It's a terrible, this is out of the Journal of Orthopedic Surgery. It's a terrible article, but it looks at the histological changes and it shows that you will have demyelination at different spots than just where the compression is taking place, or thickening of the nerve. So there are changes, and again, every one of these articles brings up the Upton-McComas hypothesis out of 1973. So I'm just looking at this real quick. So they look at epineurium thickness, perineurium thickness, number of fascicles per nerve trunk, and area percent of myelin covered. So there's a lot of questions left to be answered, but what we can do is become more diagnostically accurate by not leaving any stone unturned, which gets us into the rest of the test. So I believe that going through a proper sequence of neurodynamic testing is absolutely critical with almost any issue we're dealing with in the periphery, and it's part of it. Now, as Shacklock would say, having strong exclusion criteria is one of the superpowers of neurodynamics that are around. In his words, 30% of cases have a neurodynamic component and the rest do not. So if you can rule that out, you're ruling out a pretty big portion of what you'd be using for treatment at that point. And I would say that, in particular, to make sure that we're not missing from a neurodynamic component, because we have various dysfunctions in the neurodynamic realm that we have to rule in and out. Mechanical dysfunctions, sliding dysfunctions. Obviously, we have the pathophysiologic and pathoanatomical. But I would say don't forget about opening and closing, which gets into the same thing as like a maximal compression test, the cervical spine, McKenzie, of the nerve roots of the neuroforamina in this scenario, because again, we're looking at, well, maybe it's not true double crush, but two areas of compression creates more severe symptoms. So rule in, rule out there. Also looking at trigger points that can mask or refer almost in the same fashion. I'm saying almost because, again, it's not going to be the exact distribution of median nerve. So when somebody presents with, it's only the first three fingers and they don't have, the partial fourth, or it's only the first two. Well, now we have different things to look at immediately. And some of those trigger points that can, go into the wrist, that can go into this area, are the serratus anterior, subscapularis, infraspinatus. Now, there are a plethora of forearm trigger points that will refer into the hand and wrist as well. And I would all hope that that's on our, hands-on palpation exam that we're going through. And if we, twitch a trigger point, do we see any referral into the hand? But then some of these that are up the chain, serratus anterior, subscap, infraspinatus, may get missed. So make sure you're, on top of your Trevellin-Simons, however you want to say it, Trevellin-Simons, trigger point referrals. Now, peripheral nerve entrapment, the school of active release technique did a really good job, Mike Leahy, of mapping out in sequence the areas of typical entrapment, compression, whatever you want to call it, from the median nerve. So starting from the brachial plexus. So if we really started at nerve root, right? So we'd say lateral foramina, then we move out to anterior middle scalene, which is where the brachial plexus passes through. Corticopectoral tunnel, then ligament of Struthers, then we've already talked about Lasser's fibrosis, pronator teres itself, flexor digitorum superficialis, and then the carpal tunnel. So those would be the sites that we're kind of, looking at. Mike Leahy, I'm not going to put a number on it, but thinks that, pronator teres, pronator syndrome, whatever, is involved in a lot of these cases. I think, you hear him talk, I think that's involved in foot pain sometimes. I don't know. But again, in our clinic, via our process that we go through, we're always trying to make sure when we have symptoms in the periphery that we're ruling out spine, however you want to do that, McKenzie method, whatever, going through a neurodynamic exam, going through a trigger point exam, and then going through a biomechanical exam of, well, how does this thing move that may be creating dysfunction? And we're recognizing the dysfunction on palpation, neurodynamics, McKenzie, but then what may be leading to that from a motor control standpoint? And then you're wrapping a bow on that with, okay, how do we approach this from a treatment standpoint, which we'll get to here in a second. We can't get out of this discussion without talking about nerve conduction velocity studies. A specific quote on this, again, this article, basically, I think it's accuracy of nerve conduction velocity studies in carpal tunnel, something like that. Again, it's cited in the notes below, but here's a quote directly from that. Although sometimes considered a gold standard for diagnosis of CTS, carpal tunnel syndrome, many hand surgeons feel that NCS, nerve conduction studies, add little to the positive predictive value of clinical symptoms and signs. Indeed, NCS are not a perfect test, with sensitivities ranging from 49 to 84%, which is interesting because other articles that I read didn't give a variance range, but said that the sensitivity in carpal tunnel syndrome was 95%. This is not even saying that, and this is going as low as 49%. But when it did hit on reduced nerve conduction, which is then we have to kind of postulate, well, why is that happening? Thickening, demyelination, double sites of compression, that it was specific from 95 to 99%. So again, if we can pick up something, then it does get specific for carpal tunnel. But then again, what are we talking about? Severity symptoms go up with 2 sites of compression. So if we're seeing a nerve conduction slow down, in this case, that we have axonal flow is slowed down, that we might say, well, if the symptoms are severe enough to show up on an NCV, that we probably have another site of compression, via the study from Nemoto. Just a hypothesis. And then, in my notes here, I have at the end of this diagnostic, which we just said, is looking at the motor strategy that may be at the root for some of this stuff, which I'll do another video on central sensitization, because in this scenario, I don't want to get into that. Let's just say motor control, motor strategy that may have led to the aberrant motion. It could even be not an aberrant motion. If you're a pitcher and you're taking your elbow or your shoulder into massive external rotation moments, elbow valgosity, and just like stretching the ulnar nerve across that area, I mean, you could create a pathology there. Same thing if you're a desk worker resting on your wrist all day. We know that can be aggravating. We think of hand loading sports, gymnastics, tumbling, things where you're going to be creating impact on the carpal tunnel. Let's say now you're a female doing that, you're a little more stretchy and you can't support functionally the arch, right? It's a carpal tunnel, and you flatten that out, thereby creating more compression. That's going to be an issue. So that gets into the functional side of it, which I know then is a whole debate within the evidence-based world of, can you have a negative motion, an aberrant motion that leads to, a pathoanatomical issue or pain? Different video. In my opinion, yes. So treatment. Well, the first thing we want to discuss on treatment is we looked at, let's bring up this study. Here's an article real quick. So when we looked at comparison studies of surgery versus conservative treatment, which then the tough one with this study there is, what is the conservative treatment? Well, this one in particular, this is from 1998, looking at nerve and tendon gliding exercises and the conservative management of carpal tunnel syndrome, basically showed that 53 patients, not a huge body, but 70% reported good or excellent results, and that was without surgery. When we look at 6-year outcomes of patients who canceled carpal tunnel surgery, this out of the Journal of Hand Surgery from Europe, 2011, it showed that over 6 years, so for surgical patients, function and symptom scores improved by 6 months and were unchanged at 6 years. Patients planning surgical release can expect symptoms and functional benefits within 6 months. Overall improvements were experienced by both groups with a superior outcome achieved with surgery. But the same percentage of people found relief within about 2 years without surgery. So then the question here, which I looked for this and there's not a lot of, do you see other issues, other etiologies or injuries with a carpal tunnel release? It's a pretty minimally invasive surgery. I've sat in on a few of them. What I would say is any surgery is still a trauma to the body. And if we're, appropriately managing scarring, how the nerve moves under that, scar tissue post-operatively, we're probably going to do better. We also know that there's the kind of proxy of people who tend to do physical therapy post-operatively on any issue get better just because they did dedicated time of rehab or movement or strengthening flexibility, whatever it is. But all I'd say is that, yes, people do get reduction in symptoms. If we can rule in, rule out that it's true carpal tunnel and maybe we do have 2 sites of compression, and let's say in this scenario we're dealing with a 55-year-old woman with severe lateral foraminal stenosis, or let's say moderate lateral foraminal stenosis, and then we also find that on examination they have true nerve compression or entrapment at the carpal tunnel. Well, barring a cervical fusion, which is a much higher risk and lower success rate surgery, I would pick the carpal tunnel surgery in that scenario if conservative treatment failed, which I would always say, let's climb the tree of triage. Let's climb the triage. We'll play around with that later. Appropriately, don't start at the top. You can always go have surgery. You cannot go backwards. Now, where do we have to be certain that we do get people into surgery in a timely manner? Obviously, if you're having permanent nerve damage, atrophy, things that may not, change, even if we did relieve symptoms over time, that you may, have a loss of fine motor or gross motor skill or activity within that hand or wrist. So that's where you got to do your due diligence as a clinician. The whole reason I do these videos is so you can become better, be on that path to clinical mastery. And let me know your thoughts. If you have any questions on carpal tunnel, I feel like I tried to do my best to cover the bases as best as I could. And the tough thing is with when we're going over diagnosis like this is that almost nothing, I would say almost nothing. If you have a fracture, you have a fracture. But if you have lumbar disc herniation with sciatica, and we can look on an MRI and see that you have a honking, herniation there, and we see abutment of, the nerve, it still doesn't mean that's what's causing your symptoms or what led to that. Are there other, what if we have a disc herniation, we have another side of compression, and in that patient, the symptoms are worse because, again, we saw the discussion out of Nomoto. The human body is complex. Pain is a complex, misunderstood perception. And then we throw in that we have actual injuries and pathophysiology that we have to deal with. That's why you got to be a really good clinician, do your due diligence, do the best you can, and maybe at the end of the day you do have a drink and just sit back and say, might not figure it all out, but I'm trying to do my best. So let me know what questions you have, and I'll see y'all next time.